Now I invite Dr. Remya Edachery to talk on From Atom to Lamp, what do we know about low-dose atropine in myopia?
Good afternoon. Thank you, Dr. Nina, for that opportunity. So I'll be talking on From Atom to Lamp, where do we stand? As we know, our patient care is always based on evidence-based medicine. Previously, we know the myopia had only glasses. Now we have a lot of interventions to prevent the progression, like outdoor activity to glasses to orthokeratology. So I'll be talking mainly on myopia, atropine drops in the prevention of myopia progression. It's as you all know, atropine is obtained from Atropa belladonna, which is otherwise known as deadly nightshade. It is a non-selective muscarinic antagonist. It was first described by Wells in 19th century, and later on Bedsonian conducted a non-randomized trial on of atropine in myopia. So the mechanism of action is not actually understood, but it blocks the accommodation, but it is mainly the non-selective muscarinic antagonistic activity that is causing prevention of progression. So there are muscarinic receptors in the sclera that increases the scleral rigidity. It also affects the dopamine neurotransmitter release, which could also affect the growth of the eye. There are muscarinic receptor pathways in the choroid that is causing rapid and transial choroidal thickening. So antagonistic activity will be opposite to that. And sometimes what happens is when the systemic absorption happens, it suppresses the growth hormone from the pituitary gland, which could also affect the eye growth. So there are a few landmark studies. One is the Atropine for treatment of myopia 1 study. This is a randomized controlled trial which is double blinded. You have the pie chart. That is the population is 400 children with 6 to 12 years in myopia less than -2 diopter and astigmatism less than 1.5. Here atropine 1% is put in one eye and the other eye is untreated, whereas the control includes placebo in one eye and other eye untreated. And they have looked for primary outcome as changes in spherical equivalent and axial length. And it was a 3-year study with 2 years of treatment and 1 washout period, 1 year of washout period. So according to this, you can see the uppermost part, the atropine treated eyes, the myopia was least progressed in that around -0.25 diopter, whereas in the untreated eyes, it progressed to about -1.25 diopter. There was about 77% reduction in the progression with 1% atropine eye drops. So coming to axial length almost remained the same with atropine 1%, whereas all the untreated like placebo and other untreated eyes, it increased. So the conclusion of this study is that 1% atropine reduces the myopia progression. But we know that atropine has lots of side effects like loss of accommodation, blurring. So the child may have to use bifocal glasses for near vision and also tinted glasses for photophobia. So that's what ATOM 2 study is looking at. While we reduce the concentration of myopia, can we achieve the similar progression? So this is ATOM 2 studies, atropine for the treatment of myopia 2 study. This is also a randomized controlled trial, double blinded, similar group of children. But here we should remember that atropine slightly lower percentage, 0.5, 0.1 and 0.01% in both the eyes. Previously it was only one eye. And placebo in the both eyes as a control. And similar outcome, and it was a 5-year study with 3 phases. The children were grouped into 3 subgroups in a 2:2:1 pattern. And comparing 1 and 2, it has a slightly higher, older children and larger myopia in the ATOM 2 study. The phase 1 was year 1 and 2 where it is treatment years. The phase 2 was a washout period, and phase 4 and 5 where the continuing progresses were restarted on treatment with 1 dosage. So what they found that atropine 0.01% has very little effect on pupil and accommodation, but the other 2 doses did cause pupillary dilatation and other problems. Now we compare the myopia progression. You can see the topmost one is the atropine 1% in the ATOM study and lowermost is the placebo. So you can see the placebo, the maximum progression happened and the atropine 1% is the least. But even the lower dosages had a similar effect with the atropine 1%, even though it is not as much as 1% atropine. And so lower dosages are almost as effective as 1% atropine, but in reducing myopia progression. And even if you compare the axial length, the same 1%, 0.05 and 1% almost had the similar, but in 0.01% there was increase in axial length. And you cannot compare it with an ATOM 1 study because ATOM 1 study used USG scan for axial length evaluation, whereas ATOM 2 study used IOL master. So you cannot just compare ATOM 1 and 2. So atropine 0.1% is the effective in reducing according to this study. So coming to the phase 2, where they have chopped atropine for that is a washout period. But here you can see in the 3 groups there was a rebound phenomenon, but it was least with 0.01%. It was sustained very modulated in 0.01%. So even that has a less rebound effect. And coming to phase 3, where the continued progress are restarted on 0.01%, and they found out that even after restarting, it has stopped the myopia progression. So the final pearl is that you can advise for at least 2 years, decreases the myopia progression by 50%. Retreatment post-cessation is equally effective. So 0.01% is the most effective in myopia progression. And there is an ATOM3 study not yet published. It is done in pre-myopes and low-dose myopes. And we know the problems with ATOM2. There is no placebo in that group, and 0.01% atropine has not much effect on axial length. So we have to address these shortcomings. So then comes the LAMP study, low concentration atropine for myopia progression study. So the research questions are, does LDA prevent the progression compared to a placebo? Is there a concentration dependent response effect? And what is the best concentration? So this goes through 4 phases. First year is here even lower dosages, 0.01, 0.025 and 0.05% concentrations are used. Year 2, the placebo group crosses over the group that shows maximum effect in the year 1. And year 3, there is a washout period except the crossover group. And year 4 and 5, extended treatment where the atropine is continued. So this is the population, and intervention and control I already told, and time period was about 5 years. So coming to the results, so you can see the lowermost one is the placebo, and the highermost one is the highest concentration. So the least progression happened in the 0.05%. And so also the axial length. So that takes us to the point that there is a concentration dependent effect on myopia control with low dose atropine. And 0.01% in this study, they doesn't seem to have any effect on axial length compared to a placebo. And so 0.05% atropine is the most effective in controlling myopia and axial length with minimal symptoms over 1 year. So concentration dependent effects in ATOM2 study, it remained only in the first year. It did not hold for the second year. But here, both first year and second year, it held. So LAMP 1 and 2 shows that 0.01% is twice more effective than 0.01% over 2 years. And coming to phase 3, where compare the efficacy of continued and stopping the treatment, and also to evaluate over 3 years and investigate the rebound phenomenon. Rebound phenomenon, when you compare, there was rebound phenomenon in every case, and 0.05% atropine gives the best long-term myopia control with a minimal rebound. And phase 4, the long-term efficacy of low concentration atropine over 5 years, and also PRN treatment or retreatment using 0.05% is calculated. So here they found that the continued 0.05% atropine treatment demonstrated good efficacy of myopia control. So children should be considered retreatment if myopia progresses. So to conclude, atropine eye drops do reduce the progression of myopia. 0.01% is the most commonly available and commercially available atropine with the least side effects and lowest rebound effects. There is a concentration dependent response in reducing the myopia progression. We can start as early as 5 to 6 years of age. 0.05% is the most effective with similar side effects and can increase the dose in a non-responder. Thank you.